you should greet your patient and introduce yourself. You should wash your hands, okay? And you should warm your hands also. All these are very important respiratory points. To visualize the abdomen, you have to stand at the foot of the bed, okay? Stand at the okay? And then you have to look for the abdominal shape or abdominal contour, okay? So if there is any abnormality, you have to mention, okay? For example, if the abdomen is descending, you have to mention abdomen is passively or hurriedly descending, okay? If normal, you have to say the abdomen contour is shape is normal, okay? So according to the situation. But this by standing in this side will give you more. The view will be more, okay? Full view of the abdominal contour. At the same time, you have to observe for the abdominal movement. Usually, the abdomen moves during respiration. Okay. If the abdomen is not moving with respiration, also you should comment on. Okay. ما تحتاج تصوير.
لا تكفي تطويب عشان تطويب بس.
Okay. So after that, you can come close to your patient, come to the right side, and observe for other signs. Okay. Observe for the umbilicus. Okay. Umbilicus normally umbilicus is inverted and placed or localized centrally in between the symphysis pubis and the foil process. Okay. So you can say the umbilicus normal. Okay. And inverted. Okay. Not localized, normally situated and inverted. Okay. Also, you should observe whether the patient is having any dilated veins. Okay. Dilated veins, especially yes, at the side of the umbilicus or around the umbilicus. Okay. If not, you have to mention no dilated veins. Okay. Because usually negative finding might be important as a positive finding. But usually, if the patient is having positive findings, you have to mention the positive finding at first. Okay. Then you have to comment whether the patient is having scars or not, especially surgical scars. If the patient is having any scar, you have to comment. For example, if the patient is having right costal scar as the right hypochondrium, you have to mention. If the patient is having scar on the right hypochondrium or the scar at the right iliac fossa, okay, suggestive of previous appendectomy or prostatectomy, also ever kind of surgery he did. Then also you should comment whether this patient is having striae or not. Okay, striae are linear streak, usually signify abdominal distension. Usually seen in obese persons and those who have long-standing abdominal distension, like those who have ascites. Okay. So also you should comment on the hernia, okay? Especially periumbilical hernia. So for hernia, you have to ask the patient to cough, okay? To turn his head to the other side and to cough, okay? We call this cough sign. If the patient is having a hernia, for example, umbilical or periumbilical hernia, while the patient is coughing, the herniated part will bulge, okay? Then you have to test for the other types of the hernia, inguinal and femoral hernias. Okay. So exposure. The good exposure of the patient position. Let us start by position. Okay. Supine position might be patient can be supported by one pillow. Okay. And you have to expose him to
the from the breast,
from the symphysis pubis to the nipples, okay? From nipples to the symphysis pubis. Okay? First of all, before conducting inspection, you should make sure the patient is lying properly, okay? And also is exposed properly, okay? Then you have to conduct this. You have to look for these signs or these points. If the patient is having ascites, for example, okay? His abdominal contour will be descending, okay? Descended, and if this huge ascites, the umbilicus will be shifted downwards, okay? So descended abdomen with displacement of the umbilicus downward is suggestive of ascites. If the patient is having, for example, pelvic abdominal mass, for example, pregnancy, okay? Also, pregnancy in the late stage can cause massive abdominal distension, but usually the umbilicus will be displaced upward, okay? Abdominal distension is upward displacement of the umbilicus suggests pelvic abdominal mass. Okay. Just before conducting palpation, I would like someone to summarize. Yes, you can. And inspect the abdomen of this patient. First of all, you would like the patient to be in which position? Suppose the patient now is sitting. Okay? You have to
Tell him to spine.
yes, greet him and okay, introduce yourself. Tell him what are you going to do. I would like to examine your abdomen. May you please expose, okay? And tell him exposure to which extent, okay? Then your patient should be lie.
Yeah.
Should lie, spine. Yes, yes.
Exposure. The radial pupils.
Up to the nipples, okay? Then you have to start inspection. Stand, yes.
No ascites.
Observe it for what? Inspection wise, difficult to say this is science or this is okay. Dissension between two guys, but you can say dissension or not doing
The
dissension.
shape of the abdomen.
Yes,
Control. No scars.
yes.
The black is normal. No affected.
But usually the aim of by standing here just to look for the control and movement. For the other signs, you can come close, okay? And here comment on control. The abdomen, for example, normal, okay? Normal.
دكتور أنا دكتور
Yes.
دكتور
Control and movement. This is the abdomen. Is the respiration or not, okay?
Doctor, not sit down for the level of the abdomen.
Yes, you can. Yeah, you can kneel this. According to the if you are short and patient, okay. So usually you should be at the level of the patient, okay. So as not to miss. So you have to visualize the all areas, okay. Especially during palpation, you might need to kneel, okay. So you should be at the level of the patient.
At the right side. Mention there's no scars.
Yes.
No ascites.
If there is, you should mention. Okay, positive things should be told.
No masses.
Yes.
No tenderness.
Mass is by palpation. Difficult to comment on mass.
I can't see visible.
No visible masses.
Yes. No visible distances. Okay?
No direct.
No visible
No
distances.
direct spine.
Sometimes if the patient is having, for example, mass, localized mass, huge hepatomegaly or splenomegaly, this can be noted by inspection. You can say the right side of the abdomen is descending. There is localized descension, okay? But in the side, you expect the patient to have generalized abdominal descension, okay?
No abdominal distension.
Yes.
No scars.
Yes.
No tenderness.
Tenderness by palpation. Still, yes, now you are observing only, not touching the patient, okay?
But
Still, you are just observing, okay? So tenderness will not. You cannot assess tenderness by inspection.
No visible pulsation.
Yes, visual pulsation.
Dilated veins.
Dilated veins.
spinal.
Spinal what? Spinal nerve usually will be seen in the upper parts of the body, okay? In the trunk and okay, arms and neck, okay?
There's no
So-
stripe.
It's unusual to see a spinal nerve here, okay? In the
Scars.
Hmm?
No scars.
No scars. Yes, you have to assess hernia process, okay?
Okay.
By asking the patient to cough, okay? So now we conducted the inspection, okay? So for palpation, I have to palpate all 9 areas, okay? First of all, I'm going to conduct superficial palpation or light palpation, okay? Okay. Yes, for your hand. This is from the south, okay? From your hand. And ask the patient whether he has pain or not, okay? For example, if the patient told you that he has pain in the right hypochondrium, okay? So this should be palpated.
The last step.
Yes, yes. The last step of palpation should be this side of tenderness, okay? So usually you have to start, okay? Right iliac fossa and keep eye contact with your patient, okay? Now I'm palpating the right iliac fossa, okay? Suprapubic area and left iliac fossa and loin area, okay? Left hypochondrium, epigastric area, okay? And right pleural hypochondrium, right loin area, and ending in the umbilical area, okay? During this light palpation, I'm looking for any tenderness. For example, if the patient is having pancreatitis, it's expected that while you are palpating the epigastric area, you might feel tenderness, okay? If the patient is having, for example, cholecystitis, okay? When you palpate the right hypochondrium, the patient will feel pain. Okay, and this can be noted from the facial expression of the patient. Okay, if there is severe tenderness, we can avoid the area. Patient, okay. So the aim of palpation, light palpation or superficial palpation, is to look for any tenderness. Okay, or any masses, superficial masses, or any rigidity. Okay, for example, if my superficial palpation reveals that the patient is having tenderness all over the abdomen. Okay, all areas are tender. There is generalized tenderness. Okay, and also the abdominal muscles are rigid. Okay, so it's suggestive of generalized peritonitis. Okay, if this sign seen in local area is suggesting local inflammation according to the site. Okay, so then you can repeat the same. Okay, the same way of palpation with deep pressure. Okay, the aim of this is to look for any deep masses. Okay, any organomegaly or any intra-abdominal lymph nodes. Okay, the same way with more pressure. So this is the way to conduct superficial palpation. Start from right iliac fossa and to go anti-clockwise. Okay, start from right iliac fossa and end at the umbilical area. Okay? If nothing present, you can say superficial palpation. This patient showed no any tenderness, no rigidity, and his abdominal muscles are soft. Okay, so this is superficial palpation. Then you have to do yes. We did also deep palpation. Okay, so superficial and deep palpation showed no any signs. Then you should do deep palpation for organs. Organs usually you should look for are liver, spleen, and kidneys. Okay, so to palpate for the liver, you have to start from right iliac fossa and ask the patient to take a deep breath. Okay, to press here, and the patient should take a deep breath. Okay. Usually the liver moves down with inspiration. Okay, so now I'm starting palpation from right iliac fossa. I'm using the radial border of my index finger. Okay, now I'm pressing here. Okay, during inspiration I'm pressing more. Okay, because during inspiration the liver will come down. If it is enlarged, the chance of finding the lower edge will be high. Okay. So I am pressing, then go up at the mid-clavicular line. Okay. Take a breath. خد نفس عميق. أيوة. I'm pressing. Yes. Normally the liver is not palpable. Normally it's not palpable. If it is palpable, for example, if you reach the lower border of the liver here, okay. So this, you can say this patient is having a hepatomegaly. Okay. So in this situation, you should give some description for this hepatomegaly. Okay. For example, if the lower border of the liver here, you have to measure the length of this liver from the right iliac fossa. You have to measure how many centimeters. And you have to measure. You have to have a measuring tape. The liver is palpable 5 centimeters below the right costal margin. Okay. Yes. Another step we will mention. So you have to measure the length and you have to assess the consistency of this liver. Is it soft? Is it firm or hard? Okay. Because according to the underlying consistency, you can suggest the underlying pathology. Okay. Also, you have to see whether this liver is tender to palpation or not tender. You can press gently and ask the patient if he is feeling pain or not. Okay. Also, you have to assess the consistency of the liver. Surface. The surface of the liver, whether it's smooth or irregular surface. Okay. And the edge of the liver, is it sharp or blunt? Okay. So these 5 descriptions should be told whenever you have hepatomegaly, okay, or splenomegaly. The length, consistency, surface, tenderness. And also you can auscultate over this can be in a step of auscultation. Okay. So if the liver is palpable, okay, after describing for these points, also you should assess the liver span. Okay. To assess the liver span to see whether this liver is enlarged because of underlying liver disease or secondary liver primary liver disease or secondary liver disease, or this is because of the liver is normally pushed down. Okay. So to assess the liver span, I'm starting percussion from the second intercostal space. This clavicular line, okay? Till I find usually percussion here because you are percussing over lungs, percussion not usually resonant, okay? If percussion became dull, this suggests that this may be the upper border of the liver. And usually it's found in the sixth intercostal space, just below the right nipple here. Okay? Just below the right nipple, sixth intercostal space. Fifth intercostal space here. Okay? If percussion node became dull, you have to ask the patient to make sure that this is the upper border of the liver. A test called tidal percussion. Ask the patient to take a deep breath. ياخذ نفس عميق. Okay? And you have to percuss again. Okay? If percussion node become resonant, confirm that this is the upper border of the liver. If it's still after the patient took a deep breath and the percussion node not changed, this indicates that this patient might have an underlying case lesion, pleural effusion, pleural thickening. Okay?
دكتور هو مع النفس ينزل لفرتين.
Yes. انزل تحت. احنا قلنا نبدا البركشن نوت هنا يكون شنو؟ اوكي؟ لما يبقى ضل هنا معناه ممكن يكون زي upper border of the liver. patient ياخذ نفس عميق معناه liver will come down. Okay? So percussion if came from dull to resonant, this indicates that this is the upper border of the liver.
تايدل يعني ايش
tidal percussion.
ايش يعني تايدل؟
Tidal percussion, this يعني as you take a deep differentiate between hepatomegaly due to liver disease or hepatomegaly due to hepatomegaly secondary to a lung condition or a lung lesion. Okay, and as the patient take a deep breath. طيب خلاص. Then you have to assess the liver span. And then liver palpable here, okay? This is the upper border and this is the lower border. Lower border محدد بشنو؟ By palpation. Upper border محدد by percussion. So this gap or this distance should be the liver span. Normally it is between 8 to 12. Okay? If the liver is enlarged, you expect the liver span to be more than 12. Okay? If it's still the liver span is, for example, 10 centimeter. It's palpable and the liver span is 10 centimeters. So most likely this liver is pushed down. Okay? Pushed down by, for example, pleural effusion or emphysema or any other. Okay? So this is about the liver. Okay? So many diseases or conditions can cause hepatomegaly. Okay? Acute liver disease that can give rise to hepatomegaly, like liver cirrhosis, early liver cirrhosis. Yes, acute hepatitis, okay? Chronic hepatitis, okay? So many acute or chronic liver disease can give rise to hepatomegaly. Okay, common acute example for acute liver disease, hepatitis. For example, viral hepatitis. Okay, chronic liver disease, early liver cirrhosis. Okay, early liver cirrhosis, and liver tumors. Okay, primary or secondary liver malignancy. Okay, all these can cause hepatomegaly. Then also you have to palpate for spleen. To palpate for spleen, start from right iliac fossa and go towards the left hypochondrium. Okay. Again, patient will help you by conducting deep breath. Okay. By spleen, you can use your tip of the finger. Okay. So you can use the radial border of index finger, or you can do like this, okay? Normally, again, the spleen is not palpable, okay? If the spleen is palpable, you have to give some description, okay? The length, consistency, and all these things should be commented. Yes, the same thing, okay? After that, you can palpate for kidneys, okay? Kidneys, left kidney, you have to place. For kidneys, you have to use your both hands. Okay, we call this bimanual palpation. Okay, my left hand now in the renal angle. Okay, the right hand in the renal area, flowing area. Okay, I'm pushing from downwards and pressing from upwards. Okay, if the kidney is palpable, it will be felt by both hands. Okay. Same technique will be done to look for the right kidney, okay? Right kidney, okay? I'm preparing for the right kidney. Sometimes, if the spleen is palpable, okay? Splenic mass can be confused with the left kidney, okay? So how to differentiate? If you find the mass here and you say this is splenomegaly, splenic enlargement. Another one asks you why is this not the left kidney? Why you are sure this is spleen?
The kidney is considered like
So how to convince? Yes.
the kidney is considered like inferior.
Yes. Yeah. The kidney usually, if it is large, will go this way. Okay. Enlargement will be downwards. Spleen, if it is large, will go towards the umbilicus and left and right iliac fossa. Okay. Sometimes, in some conditions, the spleen can reach the right iliac fossa. Okay. Some conditions can cause huge or massive splenomegaly till the right iliac fossa.
Late stage, صح؟
Huh? Late stage, and some conditions. So this is one way to differentiate. Other differentiating points. Percussion, very good. You have to percuss. For example, this is a mass here. I will percuss over the masses directly. Okay. Percussion over spleen usually double. Okay. Percussion not over kidney usually resonant. Okay. Why percussion not over kidney is resonant? Kidney is large retroperitoneal and covered by the pelvic column. Okay. So as if you are percussing over the column. So this is another important point to can help to differentiate percussion note.
Dr. Artery.
Auscultation.
I still have to differentiate between spleen and left kidney. Development. Hello. Kidney usually bimanually palpable. Okay, could be felt by both hands. Spleen is not bimanually palpable. This is another important also point.
Upper border.
Yes.
Upper border.
Very good. This is the most important point. Okay, the upper border. Okay, spleen is coming from the thoracic cage. Okay, so you cannot feel the upper border of the mass. Kidney you can feel the upper border of the kidney. Okay, the important points. Also, another point that you should look for. In a big spleen, you can look for the notch. Okay, so presence of a notch this signifies splenomegaly rather than left kidney. What's this point? Spleen has a notch. Kidney has no notch. Okay. So these are the points that can help to differentiate between spleen and left kidney. Okay. So then you can do percussion. Okay. Percussion for liver span. Suppose the liver is not palpable. Okay. I'm in the percussion. We assess liver span when we in case we find hepatomegaly. Okay. Suppose during palpation you find no any hepatomegaly. Okay. So in percussion step you should have to percuss for liver span. Okay. As usual, I show you how to percuss for the upper border. So how to percuss for the lower border? Again by percussion. Okay. Start from right iliac fossa and go above in the mid clavicular line. Okay. Percussion note here usually expected in normal person, usually resonant, okay, because over abdomen, okay. If the patient, if percussion note came to dull, this suggests that is the lower border of the liver. So you have to go up till you find dullness. At this point, for example, dullness started here. So this represents the lower border. And so the upper border is here, for example. So this distance represents the liver span. So two steps of most important steps to assess liver span. The other step is to look for ascites. Okay, the test used to look for ascites, we call this technique shifting dullness. To start percussing for ascites, start in the gastrium. Okay, percussing in the gastrium and go down in the midline. Okay, your fingers are transverse like this. Okay. Now I'm percussing looking for underlying ascites. Ascites is abnormal accumulation of fluid in the peritoneal space. Again, if the patient is having ascites because of gravity, fluid will accumulate more in the flanks. Okay? And percussion note here will be usually resonant. Okay?
Normal is resonant.
Yes, normal resonant. Okay? So till you reach the umbilicus, then you have to go either to the right side or to the left side. Okay. When you go to the right side, to the laterally, the direction of the finger should be like this. Okay, longitudinal and directed downwards. Yes. If till right flank percussion, if percussion note is still resonant, this means that the patient has no ascites. Okay. If percussion note here become dull, this might suggest this patient may have ascites. Okay. So to confirm, leave your finger in contact with the patient in the abdominal wall and ask him to roll himself to the other side. Okay. And like this. May you please roll yourself to the other side and keep your hand for 15 to 30 seconds. Okay. Then you have to percuss again. If percussion note become resonant, this suggests that this patient may have ascites. To confirm more, you have to go to the midline. Okay. So percussion note now, if there is ascites, percussion note will be dull. Okay. When the patient is supine position, it was resonant. Okay. When the patient shifted to the other side, because fluid will shift to the other side. So here percussion note will be dull. If this is the case, you can say this shifting dullness is positive. So positive shifting dullness clinically indicates that the patient is having ascites. If negative, you can say negative. Okay. Because sometimes in obese patient, because of accumulation of fat in the flanks, okay, percussion note may be here dull. When the patient roll himself to the other side, it's still no change. Okay, if this is the case, you can say shifting dullness negative. Okay.
So يكون سباين يكون ريزونانس لما يكون على الجنب يكون دبل. نورمال.
Yes. لا مش نورمال. لا normally resonant.
ريزونانس هنا بيكون سباين. ولما يعني على
And normally percussion note is resonant. Okay. If percussion note is resonant is the midline and dull at the flank, you have to do this test. Okay. If no change, you can say shifting dullness is negative. If there is change, you have to say shifting dullness is positive. Does this point? After that, you can do auscultation. Okay. Before doing auscultation, I would like someone to do superficial part, just to revise. At the end, also we will do. Yes, you. أنت عملت البيت؟
لا مو.
Yes. Show me how to palpate.
طيب أول شيء نبدأ من اللي هو الرايت إلى الفصة أو السوبرفيشال. نمشي على التسعة.
Before placing your.
شوف وجهه كمان.
لا ask him to.
hand,
and ask him to.
line.
تعمل البداية أنت عملته شنو
خلاص بعدين على طول سوبرفيشال بعدين ديب.
ask him
شو
if he has pain or not, okay?
يا tenderness مع إنه شوف وجهه كمان.
Yes. Suppose you ask the patient and he told you no pain.
Yes.
Yes. Now you can.
طيب نبدأ من اللي هو الرايت إلى الفصة ونمشي على السوبرفيشال. بعدين عندك الليفت.
Your whole finger, not the tip of the fingers, okay?
الهاند كمان.
And keep eye contact with the patient. Okay? ممكن يكون ما عنده pain, but يكون عنده tenderness somewhere, okay?
صح. تمام. بعدين
to end at.
بعدين lumbaricus.
Yes. And what's your comment يعني? Suppose all normal. What you will say?
يعني no tenderness, no masses, no rigidity. اوكي. بعدين نبدا بالديب. طيب دكتور هنا الديب نخليه ياخذ ديب بريث ولا لا؟
لا قبل ما ياخذ ديب بريث same thing should be repeated but you have to press more. Okay.
اوكي.
Deep palpation.
حنتم في الفنجرة.
Yes. Very good. Yes.
بعدين
again deep palpation reveal no any masses. No. Very good.
بعدين نبدا اللي هو في شو اسمه هذا في اسمه في البركشن.
Very good. Yes, you. Then show me how to prepare for the liver.
For the liver.
start from the right ear fossa.
How can the patient help you?
Ask patient to take deep inspiration
Yes.
with the right border, with the radial border.
Suppose you find the mass.
If we
Yes. Suppose you find here
The
the lower
end.
border of the liver.
أيوة يعني نوصفها
Yes.
نقول
How to describe? Yes.
consistency
How to
and
describe this mass? Very good.
consistency and tenderness.
كيف نعرف الكونسستنسي؟ خلاص
firm hard or
لا
soft.
لا تعمل كيف؟ يعني هنا this is the lower border of the liver. خلاص هنا this space of white basy liver mass. Okay. So how to describe?
describe بس يعني شوف الإدج هل هي sharp or
Very good.
not sharp
Okay. Look for the edge of the liver. Is it sharp or blunt?
or
Very good. طيب ثاني.
and the consistency if it's
Consistency.
hard or soft
Yes.
and the
How
tenderness.
how to know this hard and this soft?
by
Hard as if you are pressing on a stone. Okay.
Ah,
As if you are pressing on a wall. Okay.
by feeling.
Soft as if here this area. Okay.
وبعدين اللي هو التندرنس شوف هل في ألم مع البالبيشن or لا or not.
So this is soft, this is firm, and this is hard. If you press here, this is soft. Okay.
Firm.
This is firm, and here, if you press here, the frontal bone, this is hard. Okay.
and another description like what
Tenderness.
tenderness.
I press over this mass and ask the patient whether there is pain or not. Okay. Can surface. Surface is smooth or irregular surface.
surface
Okay.
smooth or irregular.
Yes.
but upper border برضه by percussion. upper
لا
border.
يعني if you find the liver palpable, you have to assess the liver span,
Yes.
overall liver span. Yes.
Start from the second intercostal space. Until reach the dullness of the. If there is dullness of the liver, ask patient to take deep
Until you find dullness. If I find, for example, is dullness started here.
Yes.
Okay. So this.
Ask the patient to take deep inspiration
Yes.
to assess the tidal percussion.
To do that verification. Yes.
Right.
Very good.
بعدين يعني take the reference bar.
شوف have to take this space. Distance. Okay. طيب suppose the liver is not palpable. Okay. Liver not palpable. Yes.
على طول spleen.
Yes, you have to palpate from the spleen.
From the right ear
To
fossa.
assess overall liver span can be left, okay, till you reach percussion step, okay.
Ask patient to take deep inspiration while I assess the liver splenomegaly.
Doctor, but
The
I
other
use two
hand,
hands.
yes, okay, as an
ضروري هنا.
yes.
والله كيف إبراهيم. Ask patient to take deep inspiration.
Yes. Yes. So suppose the spleen is not palpable, okay, what you will do? And what is the patient is good, okay? And now I'm palpating for the spleen, and the spleen is not palpable, okay? And from history, when I took the history of this patient, I suggest splenomegaly in this patient. For example, this patient presented with upper GI bleeding, and there is high suspicion of portal hypertension, okay? So splenomegaly is a common sign of portal hypertension, as you know, okay?
Yes.
So while I am palpating for spleen, while the patient is in this position, I find no splenomegaly. Any other maneuvers that you can do?
confirm
Yes. So ask the patient to roll himself to the right side, okay? And again, you have to palpate for spleen. But in this technique, you can start
umbilicus.
over the umbilicus, okay? Above the umbilicus, okay? Because if the patient is having spleen, it will be mild splenomegaly, so big splenomegaly. Then you have to palpate for spleen, okay? So this is a good technique to look for mild splenomegaly, especially if there is suspicion of splenomegaly, okay? So it's not routinely done unless there is suspicion of
And
splenomegaly.
sometimes percussion يعني in the thrombus area. If
Now
there is-
forget about troops area, okay? This palpation, okay?
بعدين آخر شيء اللي هو الكدني.
Yes.
الكدني by manual.
No, your right hand here. Right.
right hand هنا.
Left there. Unless you are left-handed, huh?
لا لا right hand.
Pushing from down and pressing from
Up.
right hand, okay? The same thing, okay? طيب, very good, yes,
هذا اللي هو الفالفيشن.
yes.
فالابريشن برضه ممكن مع الخلط.
بعدين نشوف
طيب. Very good. Now you percussion for liver, spleen, and kidneys. Very good. طيب. What else? Very good.
أسيدايز.
Huh?
أسيدايز.
Ascites. Percussion for ascites. Like you percuss for liver spine again. Suppose this patient has no hepatomegaly. Okay. If the patient has no any palpable liver, you have to look for liver span by assessing the upper border and lower border of the liver, okay? Or by percussion, okay?
إذا وجد دفع سبارز نبدأ
How to assess the upper border of the liver by percussion.
بايبركشن.
نبدأ من السكند
سكند انتركوستال
intercostal space. كيف نعرف إنه السكند intercostal space؟ Corresponding to the angle of Lewis. Very good. Okay. تمام. Percussion usually will be in intercostal spaces, not over ribs. Was this point? You are left-handed. Huh? Very good. Yes. In normal situation, percussion not here or resonant. Okay. If dullness started هنا خلاص ما في dullness. ممكن يكون this is upper border of the liver. Okay. So how to
ask the patient to take a deep respiration.
very good. Yes.
He will try. If resident is this is the location of the upper border.
Yes.
If dullness maybe
Yes. So still the patient took a deep breath or percussion not continue.
maybe
يكون في underlying طيب خلاص الآن the percussion note كان اوكي معناه the upper border خلاص حددت هنا اوكي how to define the lower border
find the available
percussion right إلى الفصة مش كده؟ عمل percussion من هناك وتعال فوق اوكي نفس and go upward corresponding to the mid line okay تمام till you find dullness تمام خلاص هنا dullness started from here okay so this distance is the liver span
أخذ
تقيس المسافة
صح لما نسمعني إلى 12 سم.
تمام طيب بعد كده how to percuss for ascites
السايتس هنبدأ من هنا.
من وين؟
Yes.
The line is very good.
عند الأمبراكس عمل البوزيشن.
في البلبيشن يمكن ناخذ الريباوند وقت ندير البلبيشن يمكن ناخذ الريباوند تدنس.
الريباوند usually يكون في مع مثلا specific inflammation or infection inflammation especially if there is underlying local peritonitis. Okay, when you remove your hands, patient will feel more pain. Okay.
هنمشي لا تاخذ الباكشن.
And at this level أهم حاجة تعرفوا is tenderness. Okay, we count tenderness later on. Okay.
Resident
If there is if resident still you reach the right flank, خلاص no clinically most likely this patient has no ascites. Okay. If there is numbness,
ask patient to shake motion.
خلاص هو تقلب كده.
Take maybe 30 seconds and do percussion.
Very good.
If resident maybe ascites.
أنا كنت confirm تمشي لغاية الميد لاين. Okay.
لازم حمشي على
لغاية الميد لاين هنا. هذا المايكس هنا. So percussion note.
النص.
قبل البيشن بالقلب كان ريزونانت الان بعد ما القلب بقى دبل اوكي بوزيتيف شيفتنج ساينس طيب وات كوزز اسايتس خلينا نخلي في النهايه ديسكشن خلاص فيري جود الان نركز على التكنيك طيب سكالتيشن عندهم سماعه okay you have to place your stethoscope here okay هنا for bowel sounds. Okay.
Under the umbilicus.
Okay. Around the umbilicus. Okay. You can start here below the umbilicus. Okay. These areas. Okay. نسمع هنا سمعنا bowel sounds خلاص ما سمعنا you can place your
around the umbilicus.
Yes, around the umbilicus. Okay. Bowel sounds are gurgling sounds. supposed to be audible every person, okay? Every normal person you can have bowel sounds. Exaggeration of bowel sounds usually seen in those who have mechanical bowel obstruction. When very exaggerated, okay? Who more increased. Absence of bowel sounds usually indicate peritonitis. Seen in those who have parentic areas or peritonitis. Okay? So first of all, you should auscultate for bowel sounds. Then you should
لكن نسمع لازم تمرجع فترة يعني
هنا ما سمعنا تمشي ثاني اريا ثانيه around the blacks. Till you hear. 4 minutes all area you fail to hear, most likely this patient is having parentic areas or peritonitis as a differential. Other sounds routinely you should auscultate for renal bruit. So this is the area to auscultate for renal bruit. Above and lateral to the umbilicus. Here for the right and here for the left. A bruit is a murmur heard over stenosis artery. And for example, if you hear the murmur here, you can say this patient most likely is having right renal artery stenosis. Same things will be here. Okay. So bowel sounds. Suppose you heard the bowel sounds, you can say bowel sounds are audible or heard. Okay. Then you have to auscultate for renal bruit. Okay. No any renal bruit, for example. If present, you have to mention. Okay. Then you have to auscultate above the umbilicus in the midline. Okay. For any aortic, for any murmur that can suggest aortic artery stenosis here, or abdominal aortic aneurysm. If there is suspicion of portal hypertension can produce a murmur called venous hum. The best area to look for venous hum in between the umbilicus and the fistula. Here, in the whole midline. But usually venous hum in between. In between the umbilicus and the fistula. And venous hum is usually specific for portal hypertension. Will not be seen in any other condition. Okay.
Sound.
Murmur.
Yes. There are murmurs.
Yes. It's called renal bruit. Renal bruit. Bruit is a murmur over artery. Okay. Venous hum also a murmur due to high flow of blood in the umbilical vein, and this is usually seen in portal hypertension. Okay. Then, if the patient is having hepatomegaly, for example, bowel liver, okay, you can auscultate over this liver mass. Again, sometimes you can have bruit over the liver, murmur over the liver. Especially this condition is seen in those who have liver malignancy, vascular carcinoma, because it's highly vascular, so it can give rise to a bruit.
liver bruit.
Yes, liver bruit. Again. Auscultation over the liver can reveal a sound called friction rub. Okay, friction rub. Friction rub also can be seen in those who have liver malignancy and alcoholic hepatitis. Okay. Also, auscultation over splenic mass. Okay, sometimes can reveal splenic friction rub, especially those who have splenic infarction or splenitis. Okay, but all these sounds are rare in clinical practice. Okay. But usually now concentrate for auscultating for bowel sounds and renal bruit. Okay, and those who suspected to have portal hypertension, routinely you should look for venous. And routinely also you should auscultate for any aortic artery aneurysm. Okay, so routinely bowel sounds, renal bruit, and auscultation for abdominal aorta. Okay, situation of portal hypertension, you need to auscultate for venous. So these are the most important points. Now,